Good morning, good afternoon, and good evening, everyone. I am thrilled to welcome you to today's meeting of the Davos Alzheimer's Collaborative Health System Preparedness Learning Laboratory. We've got a great lineup this morning or this afternoon or evening, and I'm very excited to kick off our discussions. So we're welcoming about 450 people this morning, representing about 50 countries. So we are thrilled with our global reach here. And I'll start by setting the stage and then tell you a little bit more about the agenda that we'll walk through today. So, as is no surprise, we're in a moment that is very optimistic and pivotal in Alzheimer's care. So, over the last 5 years, we've seen significant advances in both diagnostics and evidence-based interventions, whether they be risk reduction or pharmacological. But as many of you would know firsthand, the journey from clinical validation to access at bedside is a challenging and fraught one, where we need to see changes in clinical medicine, changes to policy incentives, and structural and logistical barriers for patients to really access these novel innovations. So that brings us to our framework for this morning, which we draw from Clay Christensen's Innovator's Dilemma, where he eloquently lays out the tension between bold future-facing breakthroughs with the lived realities today faced by patients, clinicians, and families in Alzheimer's care. At DAC, we believe that we need to work on both time horizons simultaneously to realize change. We're very excited about the innovations on the horizon, whether we're talking about next generation blood tests, AI decision tools, or more personalized models of risk reduction. But in most settings, the barriers we really see for patients and families today aren't science. It's relatively low levels of system implementation capability today. And if we want innovation to take holds, it's important that we'll build operational capacity now. And I think as we walk through our panelists this morning, you'll hear how they're thinking about that and the steps they've taken to start building that capacity. And so that brings us to another Christensen concept of the wide lens, where he challenges us to think beyond product and really consider what is the environment that implementation needs to take hold. And so when we look through healthcare systems globally, we see significant differences even within a single country like the US. And so if we don't account for that variability, dissemination fails. So our approach to system preparedness is really grounded in not only adoption, but adaptation, where we work in our studies with healthcare systems to understand what barriers look like in different systems and the tailored implementation strategies that show efficacy in meeting those challenges and barriers. So to underscore why near-term implementation really matters, I think in the field today, there are many innovations in development that have the potential to significantly expand access to improved diagnostics and care for patients. And in our work with health systems and dozens of health systems at this point, we know that those new innovations will need to, at some point, interface with the humans and systems that make up health systems today. And by implementing clinically ready innovation today, we really build the capacity of systems to absorb those future-oriented innovations that really have the potential to radically expand access. So turning to our agenda today, we've structured our speaker around three key phases of innovation. So we'll start talking about 0 to 1, where we're taking an idea through regulatory approval and validation. So we'll give you a backdrop of our programs and mission and our work on early detection to date. In our second section, we'll move from one to many, where we'll talk about expanding access and implementation in high resource settings. And so we'll spotlight a new program we have in the UK on early detection, as well as our 2 US early detection programs, the US Fellowship and Brain Health Navigator program. And finally, we'll end with a section on many to all, where we'll talk about scaling globally without relying on high cost infrastructure. And so we'll turn to low resource settings and show how those settings are not just adapting models, but leapfrogging in many cases. And we'll really foreground creative implementation in these settings that may point the way forward for others, including high resource systems. And finally, we'll close with a call to action for bold partnership, policy alignment, and urgent momentum. So turning now and grounding in the DAC-SP mission over the last 3.5 years. So in 2021, we had 7 pilot sites in 6 countries. And today we're moving towards having, by the end of 2025, more than 70 sites worldwide implementing some portion of a diagnostic pathway. The initial program we completed was the early detection program across 12 countries and 19 sites, which deployed blood biomarkers and digital cognitive assessments. And that study culminated in the Blueprint for Health System Preparedness, focused on early detection. That resource was co-designed with our site leaders and is available today free. And as we've moved forward with that blueprint, we've wrapped several dissemination programs around it. So in the US, we have the US Fellowship, as well as Brain Health Navigator program, as well as the UK program we'll talk more about this morning. Separate from early detection, we've also launched an accurate diagnosis program, which is active in 8 sites globally, that's focused on how blood biomarkers can reduce bottlenecks to specialty care. We're applying that same implementation framework in an additional 6 EU-based sites as part of the IHI-80 Riddle Consortium. So through these programs, we expect to train hundreds of providers and enable access to diagnostic services for tens of thousands of patients. And we're really thrilled about what's to come based on this positive early momentum. So today we'll talk about our dissemination in the US work in depth. But I'm thrilled to announce the next significant program that we're launching in the UKA DCA demonstration project, which is our first formal partnership with a national government. And to tell you more about that program, I'm thrilled to welcome my colleague Phyllis Farrell this morning. Morning, Phyllis.
Hi, Tim. Good morning. Can I just pause for a minute? And we never get to do this because we're always running at 100 miles an hour. But going from 6 sites to almost 70, it's so much fun to hear you say that. So it's really exciting to see how far this has come. And thanks to you and the entire team for your leadership in getting us there.
Agreed. So I'll start out with a very easy question for you. Can you tell us about the DCA demonstration program in the UK?
Absolutely. So in the UK, we're launching a demonstration project, which is another implementation model for digital cognitive assessments. And it's actually a collaboration, not just with DAC, but with Innovate UK and the UK Office of Life Sciences under the Dame Barbara Windsor Dementia Mission. And as you mentioned, this is really the first time we've had that direct public-private partnership. And that's, what we were founded on. So it's very exciting. It's embedded in the readout study, which is a £4.5 million program that's led by Dementia Platform UK, and it's supported by Alzheimer's Research UK, the Alzheimer's Society, NIHR, Gates Ventures, among many others. So the program will actually test how digital cognitive assessments can be layered into the rollout of blood biomarkers in a real-world NHS setting, which, as we all know, is really important because these blood biomarkers are really validated for people with cognitive impairment. So you need to have a good, solid, robust cognitive assessment, and that can be difficult to do in a real-world setting. So we're going to be using technology to see if we can make that a bit easier. And so DAC's role will be like what we do with any other of our programs, is we will be supporting that implementation strategy of a clinically ready innovation, and then we'll do the evaluation and run the community of practice, which is our national learning kind of community model that we've used in our other programs.
Great. And I know I'm jealous I was not at the World Dementia Council meeting where the program was launched. I know that you were and sort of got a better sense for the response in the room and how people sort of process this in the context of the NHS and the UK system. Can you tell me a little bit about what that was like and what the response was?
Yeah, I mean, it was actually launched at the kickoff of the World Dementia Council Summit by the Minister of Health and Life Sciences and Technology. And so I think everybody's excited about taking innovation that's been so hard won. I mean, if you think about like where we've been in Alzheimer's disease research, 30 years, 35 years without therapies, and none of these therapies are going to get to the right people if we don't do early detection and accurate diagnosis. And so this idea of how do we make sure that the diagnostic pathway is pragmatic, practical, it can work in a real world setting, not just in clinical trials. It was a very positive response.
Amazing. And you started out by talking about, kind of the journey from 6 to 70 sites, which I think both of us are very proud of our team for doing. But
And
can you
maybe have a little gray hair.
So can you sort of talk about, I mean, obviously there are more than 70 sites in the world. There are many healthcare systems. So can you tell us a little bit about why this is so important to our system preparedness mission?
Yeah, so I mean, as I said earlier, DAC was really founded with the need for public-private partnerships. You mentioned Clay Christensen's model. In a lot of consumer packaged goods, basically, and those types of innovations, the government really needs to get involved in that many to all phase when you go from high resource to kind of all populations around the globe. But the thing about healthcare transformation is the government really needs to be involved in the one to many. So I think that's why this is so critically important. Obviously in the NHS, you've got a single payer system. You've got to have government involvement to make sure that this moves. Even in the US, where we don't always think of ourselves in a single payer system, in the US with Medicare for everybody 65 and over, which is obviously a lot of our Alzheimer's population, we're a single payer system here. So that government involvement is really critical. Otherwise, things just won't get to the people who need them the most, or who could benefit from them the most. And then, of course, for those of us who have been around in this space for a long time, it's not lost on me that our first government partner is the UK, because back in 2013, when former Prime Minister Cameron had the G8 presidency, a lot of this global action on dementia was launched. Everything from the first Amavid dose to the activities that ultimately led to the Lausanne dialogue, and of course, all the success we've had with multilaterals. And so it's really exciting to see the UK come back in that leadership role again.
Great. Well, thank you so much for telling us about the program. I know that you had a late flight last night and are running on a few hours of sleep, so we really appreciate you.
Well, I'm excited to learn and listen to the panel. So thanks to all of you too.
Great. I am now pleased to introduce our next session on From One to Many, introducing the U.S. Early Detection Fellowship and Brain Health Navigator program, and our moderator, Dr. Mike Hornbecker, who leads the fellowship program. We're very excited to talk about these programs today and build upon the learnings from our early detection program, which you've heard about in previous meetings. Alyssa will add the press releases announcing those programs to the chat if you haven't already seen them. And with that, I will turn it over to Mike.
All right. Thank you very much, Tim. Good morning, everybody. As you heard Tim sort of mention during his remarks, DAC's first early detection program ran from about 2021 to 2023. And it was based on those learnings that we created the U.S. Early Detection Fellowship Program to better understand how U.S. healthcare systems can implement standardized cognitive screening tools in clinical practice in primary care settings. It's also an opportunity for us to really pressure test, if you will, and further develop the blueprint that was a byproduct of that first early detection program as well. And as a reminder, that's an open access implementation guide. And during the course of the U.S. Fellowship Program, we will modify it and adapt it so that it's a better resource for U.S. healthcare systems. So last year, we were fortunate to launch the U.S. Fellowship Program in 10 U.S. healthcare systems representing diverse populations. And this program will continue through the spring of 2026. In parallel to the U.S. Fellowship Program, we've also launched the Brain Health Navigator model. That was launched in early 2025 and is a 6-month program that includes 6 U.S. healthcare systems who are working together to co-create and implement a brain health navigator model to really help facilitate the diagnostic journey of each patient. So without further ado, I'm very excited to introduce site leaders from both the programs that I just described to you to share some insights with the group. And here they're all popping on. So what I'll do is I'll have each of our panelists introduce themselves. We'll ask you to just kind of say your name, your role, what healthcare system you work for, and then sort of briefly describe for us the geographic setting of your healthcare system and the population that you serve. So Lori, we'll start with you.
Certainly. Hi, everyone. My name is Lori Harris. I am a doctorate of public health and a registered nurse here in Southern Indiana, right across from Louisville, Kentucky, sort of middle America. And I work for a federally qualified health center, the Family Health Centers of Southern Indiana. Our main population is mainly the uninsured, low income, uninsured, underinsured, and the working poor. And so that's our demographic. And we are part of a larger system of federally qualified health system centers across the U.S. We receive federal funding. So there's about 1,500 of us nationwide, but we're unique and independent here in our own organization. And so we mainly serve the underserved. And so we're excited to be a part of this project.
Great. Thank you, Lori. Thanks very much. Elise, why don't we have you go next?
Of course. Good morning. My name is Elise Smith, and I'm a project principal at Scan Health Plan. Scan Health Plan is a Medicare Advantage plan, obviously serving seniors. We're really proud of our beginnings in the community of Long Beach, California, where we had 12 angry seniors kind of band together and create what Scan is today. We now serve over 300,000 members or older adults across California, Arizona, New Mexico, Nevada, and Texas, in partnership with over 90 medical providers in rural, suburban, and urban areas. So we're happy to be here.
Great. Thank you so much, Elise. We're happy to have you. Stephanie, we'll have you introduce yourself next.
Hey, good morning. I'm Stephanie Viverberg. I'm a nurse practitioner in the cognitive neurology program at Emory Healthcare and serve as our director of cognitive care optimization for our Goizueta Brain Health Institute at Emory University. So we've had a long history in cognitive care at Emory and through our partnership with Georgia MemoryNet, which is a state-sponsored program establishing diagnostic clinics across our whole state, but have been excited to be a part of the DAC Community Fellowship as we serve and work with our primary care providers here at Emory Healthcare. And so this fellowship is really focused on partnering with our close to 50 primary care clinics that span Metro Atlanta, very diverse population of close to 50% minority across our city, and over close to about 80,000 patients over the age of 65 that we serve, in addition to the rest of the folks that come in through our primary care clinics. So really excited to be a part of this program and to see how our primary care clinics can partner with our cognitive specialty clinic to really optimize care and early detection. So thanks so much for having me, Mike.
Great, thank you. Ihab, we'll move to you next.
Good morning. So my name is Ihab Hajar. I'm a physician at the UT Southwestern. I am the section head for the behavioral neurology program here. We are very lucky to have this partnership with the DAC group. We have a large primary care network that extends in the big metroplex of Dallas-Fort Worth area. So we are trying and planning to institute a screening program in this large network, starting off with a few selected sites. We've selected geographically diverse sites, one in the southern part of DFW, which has about 80% diversity in the primary care, general internal medicine academic clinic, as well as in the neurology vascular clinic. So we're hoping to get some more information, to learn more about the process and how to implement this screening program with a direct link to our specialty clinic. So we are able to not only screen, but also offer services with the liaison between the cognitive neurology, behavioral neurology program, as well as the primary care. So this hopefully will be a great example of how these two could align together in this initiative.
Great, thank you so much. And last but certainly not least, Greg from our Brain Health Navigator model. Why don't you introduce yourself?
So yeah, thank you. So I'm Greg Cooper. I'm a behavioral neurologist in Louisville. I lead our memory center within the Norton Neuroscience Institute at Norton Healthcare. We're a pretty good sized integrated healthcare system operating in a mid-sized city, also serving underserved, minoritized populations within our city in a pretty large rural area throughout Kentucky and southern Indiana.
Great. Thanks very much, Ray. Thank you all for the introductions. I think we'll begin the questions with sort of another round robin here, and I'll start with the U.S. Fellowship sites. So, each of you are adapting the U.S. Fellowship program to your local setting and the context within your clinics. Can you each tell us a little bit about how you've decided to approach the program and what considerations, if any, you kind of factored in when seeking to standardize cognitive assessments in primary care? And Lori, we'll just go back to you and have you started off.
Well, for us, focus mainly on primary care, we are often given edicts or sort of prescriptive type models from our grants and things like that. And so we wanted to model brain health, which is new for us, a new avenue for us to screen for. And so we wanted to implement some of the screening tools and things that focus more on the brain health and kind of model it like we've done for other disease systems in our setting. And so we have, as others have, we have our clinic sites. We have 4 clinic sites and then a mobile unit. And so what we do is we try to implement protocols such as pathways in our EMR. So it's very easy for our providers to follow. We have trainings for our providers and support staff so that everyone understands why we're doing what we're doing. And then we also have a clinical IT reporting staff that also gathers the data on the back end so we can see, if our implementation efforts are impactful and effective. And if we can share those at a larger scale with other health centers and maybe our models and implementation methods, what we've done and kind of ironed out the kinks, if we can spread that not just statewide, but nationally as well to other health centers to be helpful and useful and sharing, learning lab type settings as well in that type of, on our world, in the health center world.
Great. Thank you very much. We'll change up the order a little bit, and Stephanie, will have you go next. Just kind of tell us a little bit about how you've decided to approach the program and then those considerations for standardizing cognitive assessments.
Yeah, thanks so much. It's actually been probably the most crucial point for us has been understanding primary care and what their needs are, what they're currently doing, what they're capable of doing. I joke with every PCP I meet with that we know you're being asked by every specialist to be a specialist in their field as well. And so help us understand how we can make these workflows feasible for you. And so as cognitive specialists, we receive patients with every bit of data you could imagine and no data. And so trying to learn how do we standardize cognitive assessments in primary care that are both usable and feasible for our MAs, our providers, and then how do we create workflows that really get a patient to the cognitive specialty clinic that needs to be there with the information that the cognitive specialist needs to get them on the right track for care has been probably our #1 priority. And I think we've been especially excited to see that our primary care clinics have embarked upon an annual wellness visit initiative to increase increase annual wellness visits within our primary care sites across the whole metro Atlanta area in advance of our partnership with them for cognitive assessment. And so the two clinics have really been synergistic. I mean, I think there's been close to a 200 to 300% increase in ABLWVs over the past year. We won't take full credit for that, but just seeing how being able to do a simple digital cognitive assessment in primary care alongside an AWV, the win that is for patients and for providers and for clinic teams has been how we've tried to capitalize on that and approach it. And we've also tried to say, how do we build a model that's flexible? And so within our workflows, we are currently partnered with 5 sites in primary care, and we'll be joining 2 more in the next month. And we've been able to adjust our workflow 2 to 3 times already to make it work better for them. And so having that flexible approach and learning from the folks that are in the settings where they live and work every day has probably made the biggest difference for the program and for early detection.
Great, thank you so much. Ihab, we'll move to you next.
Yeah, thank you. I think we've similar to Stephanie's approach, we've in the first phase of this initiative, we've approached it in two areas, parallel areas, I would say. One is communication with the primary care and the starting from the, I guess, from, if you will, from the top down, starting from the major decision makers at the institutional level, all the way down to the individual providers, and have had multiple discussions, almost a weekly discussion with various individuals, trying to understand the dynamics and the institutional culture about this area of adding a screening tool. And really, I think what we have discovered is that a lot of that could be aligned very well with the annual visit, but also I think we're trying to expand that beyond just the annual visit to address some practices which we have met with that do not have the capacity or even the plans to have a widely universal annual visits. So that's been kind of our first encounter with the institutional culture, is trying to understand these little or these barriers that could be existing to implement this program. But at the same time, I think what we have been working on is trying to remove the barriers for primary care providers as well as other specialty providers to get their cognitive screening. And interestingly, we found a huge variability even within the same practice. So if you think of the university primary care program, there are various practices located all over, and you could and when talking to people and various providers, there is so much variability and heterogeneity in the way they do them, the tools they use, when they use them. So what we are working on now is streamline that along with the clinical informatics program to institute a institution-wide platform to use, and so that it is not very time-consuming, but also available within our electronic health record, so that they can easily pick and choose, at the time. And we are spending a little bit of time trying to figure out the best approach in this situation, trying to leverage some of the newer technology, some of the research we're doing in terms of using non-obtrusive, maybe voice recording or facial expression type of situation where we can derive some cognitive measures, as well as lining up with our biomarker activities. So it's been kind of a parallel process. It is slow in progress, but it definitely is a huge learning experience for the site leaders here.
Great, thank you so much. Elise, we'll move to you.
That sounds great. So not too dissimilar from my colleagues here, but our goal with the program and our approach is really to build a process that makes incorporating these assessments easy for both our clinicians and for our members. We understand that primary care providers have extremely long lists of things that they need to do in a singular visit. And so we really believe that simplification of process could help encourage the adoption rates of these assessments. We also really believe in our clinicians and our medical partners to really do what's best for the human in front of them. And so while we want to standardize, we want to leave those options within our system or then within the point of care for clinicians to really make that judgment on that relationship. So what we're really doing and focusing on for this experience is replacing that traditional cognitive assessment with a digital tool. And what we're hoping to learn is if it's integrated at the point of care, can that be a better experience for our clinicians? Is it more efficient? Is it time saving? And then does it help or support kind of gamify or make the process of cognitive screening for our older adults a little bit less intimidating for them at the end of the day? So we started out by mapping our process as it is today, really identifying where are the biggest pain points, what do we think we can improve upon, and then really just kind of narrowing our focus there to keep really what was in place intact, but just adding in those improvements to hopefully, again, have those better outcomes.
Great, thank you. Greg, I don't mean to keep coming to you last, but as the representative of the Brain Health Navigator program, I'm going to ask you a similar question. But so again, how you approach this program and what considerations you had when looking to standardize sort of that patient diagnostic journey, if you will, in your health system.
So we tried to come at it from two different directions. We want to build in as much flexibility as possible, understanding that there are going to be different patterns of practice, while still having enough standardization to make it make sense and be coherent. And we looked at it we want all roads to lead to the Brain Health Navigator. We want to find as many pathways into this program as possible. And we're looking at it primarily from a primary care standpoint and a specialist standpoint. And so we want to make it as easy as possible for primary care when they identify someone appropriate to refer into that person. We also want to understand that the referrals coming from the specialty office may be slightly different. So we started out from that framework. And then we had a series of discussions, both between myself, the specialty side, the primary care side. What is the real value that we're creating in all of this? And once we were able to articulate that, in a sense, that value proposition, then it made it much easier for that flow to take place. We knew what we were trying to accomplish, and we had good mechanisms for referral, both from our primary care pilot side and from the specialty side.
Great, thank you very much. I'll go ahead and stay with you for a second, just ask you a follow-up question. Sort of big picture, why did you really see a need for this sort of boundary spanning role, if you will, of the Brain Health Navigator, and what are some of the challenges that you are currently seeing that you hope to solve with this?
Yeah, so that's a great question. I think gets to the heart of this. To share a little bit of my own bias, I've always thought my part of this is relatively easy. If I'm being honest, most of the time, it's not that difficult to make a diagnosis. It's not that difficult for me to prescribe a medication, but that's really not good enough. If we really want to elevate our care, the best care comes from a team. It's a team with, disparate expertise, experience, different providers, bringing in different resources, both within and outside of the organization. If we really want to elevate care, we need to make this a team sport. To make it even a little more complicated, I've always felt conditions like Alzheimer's disease are not conditions of individuals, they're conditions of the entire family. So we need to look at this holistically and figure out how can we bring as many resources to bear on the whole family as possible. Well, that's the beauty of the Brain Health Navigator in my mind. This is the person that is the connector, the glue, that friendly point of contact, that person that can bring together all of these disparate resources into one coherent whole to elevate the care for the patient and for the entire family.
Great. I love that concept of elevating the care and being more cohesive and team-based care. I think we all sit in our silos pretty often, and it's great to pull everybody out of those silos and bring them into more of a team-based approach. So thank you for that. Stephanie, I have a follow-up for you that's sort of related to that. So I know that, like many institutions at Emory, you guys have struggled with a backlog of patients coming into your cognitive neurology clinic. So as part of this project, I know, since I'm privy to what your workflows are, that you are using something that you're calling an e-consult model to sort of streamline those referrals. Can you tell us a little bit about that and what impact, if any, that it's had on that referral process?
Absolutely. So, yes, horrifically, the worst it's been in my almost 20 years at Emory was a 17-month wait to get into my clinic. And we vary between that and about 6 months. And so, as appalling as that is, what often happens is patients wait months and months, and then they're at varying levels of cognitive impairment once they reach our clinic. And so, we've got patients with very mild symptoms who now have this very immediate need to try to match to therapies that are now available. And then those who are more in moderate and impaired stages, whose families are really struggling for psychosocial resources and such. And our only pathway into clinic for a long time was to wait till you got a cognitive testing appointment and then to wait for a clinician appointment. And then we could match you to all those services. And so what we've really tried to do is figure out what tools exist within the system to front load as much of the workup as possible in primary care, and then to give a specialist eye to the data to help those primary care providers then decide and guide those primary care providers to the right resources for those patients. And so what we ask from the digital screening is that primary care providers consider their patient in front of them, their functional abilities, their needs, and what might be contributing. And then if they do have concerns for neurodegeneration, that they order further testing. And so they're getting a brain MRI, they're getting lab work in primary care, and then they send a digital request for an e-consult to us. We can do those in about 5 minutes if we have the images and the data in front of us. We're actually doing some digital extended cognitive testing as well on the same platform that does the screen, so that we can then say, hey, this patient looks like they might be presenting with some pretty prominent hippocampal atrophy, and they've got mild cognitive impairment, and they're suspicious for possible Alzheimer's disease. Let's go ahead and offer them an appointment at cognitive clinic. Or this patient looks to be moderate to severe. Sounds like the family's already starting to struggle. Can we match you to our online caregiver course? Can we refer you to our integrated memory care clinic that does primary care and dementia care? Whatever resources, because we are resource heavy, but the getting to the resources have been challenging. And so using that e-consult model to try to kind of streamline patient care has worked quite well. Getting the test done on the primary care side has been the challenge, and that's the bottleneck. But when patients follow that workflow, it's been pretty amazing. And we've watched people go from, a 12 to 17 month wait to about a 2 to 3 month process of getting their screening, their tests done, and then straight into cognitive care. So really, really proud of the work that's being done so far, but also, learning how to work with the challenges of just navigating patients through the system. That's always going to be our challenge.
That's great. Fantastic to hear that innovation really brought down that wait time. That's fantastic. Elise, you guys also over at SCAN have had sort of a novel approach to this project, in that you're not just implementing early detection in traditional primary care settings. So tell us a little bit about your pilot sites and the populations that are going to benefit from your participation in this fellowship.
So yes, as part of this collaborative, we're looking at 2 populations. The first is a traditional primary care setting, who is doing a high volume of tests for us, so about 12,000 a month on average. But the second population is one of SCAN's most frail populations of older adults, and those are the ones who are in our institutional special needs program called Embrace. Embrace today serves about 3,500 members in 3 counties in Southern California and 2 counties in Arizona. And these members are served in a really high-touch model where advanced practice clinicians visit them in their place of residence, which is typically an assisted living facility. The average age of this population is 85, and we have about a 17% mortality rate. Based on the demographic features of this population, we do estimate that over 50% of them are impacted by dementia, but with the current tools available or that are easily deployed in a mobile care setting, we're only finding a portion of that membership today. So it's really important for us to learn and adapt kind of this early detection or screening model for this population for three main reasons. One, considering use source utilization, right? It's not efficient to refer these members to these expensive or complicated pathways without proper screening in place first. Our clinicians who care for these members are selected to do so because of their dedication and because they are highly capable of managing dementia. And so we want to give them every opportunity to do so through improved technology and process design. The second reason is a lot of these standard pathways that have been created can often be inaccessible or extremely difficult for our members who are within this population or who are maybe housebound or bedbound. And so that just creates additional frustration with system navigation or overall time delays. And so this additional focus here allows us to really take a step back and reimagine the care experience that's specific to these individuals. And then the third reason is just we really want to make sure we're putting all of our members at the center of their care and we're aligning their care to their goals and wishes. And for this population, it does look a little bit different than maybe a younger kind of 65-year-old who's going through cognitive assessments. So we're really excited to kind of be able to adapt and bring this population into this collaborative.
Great, fantastic. Lori, I want to come back to you for a second as well. So you mentioned in your introduction, obviously, that you're running a consortium of federally qualified healthcare centers. I'm just wondering if you can sort of give our audience the Cliff Notes version of what it means to be a federally qualified healthcare center, and then tell us how your approach has differed, if at all, from some of the other sites in the U.S. Fellowship Program when it comes to cognitive screening.
Sure. So the Federally Qualified Health Center sort of grant system was set up over 50 years ago, and it was sort of a project to provide access to, the most vulnerable populations across the U.S., rural, but also urban areas where there were deserts for primary care and access to care. And so there's a federal grant by the Health Related Services Administration that's competitive. And so regionally we compete to access federal funding. And then with that federal funding, there's a litany of things that we are required to provide in primary care in regards to such things as we are mandated to have case managers. We are mandated to have things. We also do not rely on billing for insurance as a normal primary care office would. We rely more on grant resources, and then also some health centers rely more heavily on Medicaid. Medicare is starting to, as populations are starting to age, we're starting to tap into that as a billing resource. However, in our setting, we have been pretty lenient on being able to access more of the billing because we are about 60 to 70% uninsured depending on the year and the federal programs and the federal settings. So we are high uninsured. Even though we are in a very high resource setting in the US, there are also demographics of our population that really have to look at things through the lens of accessing care as a low resource setting in a sense. And so what we do is we try to improve access to care and decrease those barriers to care. And one of the things that we differ with a little bit is that, the literature and some of the focus is starting to come out on how do these social drivers of care, such as poor nutrition, increased stress, housing instability, domestic violence, partner violence, how do those things impact our health? And so we, as health centers, have been looking at those in regards to things like diabetes and heart disease. And so we're looking at that. We collect that data on our patient anyway. So why not look at that in comparison to brain health as well? And so one of the things that we differ from dramatically from the other settings is that we are starting our screenings at age 50 because so many of our patients are uninsured. We don't have to rely on that welcome to Medicare visit to get that patient screened. And so we're not waiting on, being able to bill, an insurance to be able to get reimbursement to provide that service. And so what we're seeing is that, we want to compare, is that early screening and lining up with the social social drivers of health data. Is that showing early, early signs of, brain health and cognitive decline compared to the general population? And that's something that we want to see. And if so, then, that could be something we could share at our national level and share to all health centers. The other thing that we do is really, we need a longer runway to gain access to care and to specialized resources for our patients. A lot of times I say our access to care, is sort of a begging or a wing and a prayer. We depend a lot on relationships and memorandums of understanding and collaborative projects and maybe pilot projects with these wonderful resources that are out there, but are just light years away for our patients. And so it takes us a much longer runway. So when we have and identify our patients that are uninsured, may have language barriers, that are low income, or, have some of those other drivers of health impacts, it takes us a longer time to get them into care, even if it's accessible to somebody with insurance. To our patients, a lot of times it's a much longer pathway to try to get them to care. The other thing is, even when we do find a referral or a program for our patients to go to, they won't go often. And so having to hold the hand of the patient and really navigate sort of to that nth degree with our patient to show them that preventative care is important, and that with brain health, you see that it's not necessarily a cure, right? It's slowing progression. And so trying to educate as well. The other aspect is that we also have a outreach component. So we're actually we have planned for later in our project, we're actually going to some of our housing authority settings. We're going to some of the low income Section 8 housing areas in our normal outreach that we do. And we're including our education and information about the Brain Health Project and screening so that we can get in. And then once we can get in, and screen, then we can try to align and access and link to resources. One part about being a health center is that we do have access to what's called a 340B formulary. And so we have contract pharmacies. So sometimes we can get high cost drugs at a very low rate for our patients if it is allowable on that formulary through the 340B program. So if they are uninsured, or even if they have Medicaid, sometimes we have access to medications and can get those at a lower rate that make it feasible, to start early interventions for pharmacological solutions that otherwise would not be available. And so that's kind of how we differ mainly. So it's really the, early screening, the access to care, the linkage to resources, and then that outreach component. So that's how we're different, from the larger systems. But we're excited to see what we find, and if we can kind of, grow it and mushroom our findings, what we figure out from this. So it's been an interesting thing for us to do again. And it's also different because this is our first foray into brain health. And so we're learning so much, our providers, our staff, and it's really kind of energizing our staff because we are so prescribed as far as, we focus on maternal child health, we focus on diabetes, we focus on heart disease, but this is really our first foray into brain health. And it's just fascinating for us to see how, a lifetime of poor nutrition and, some of those other things really are starting to impact the brain, one of our most important systems.
Absolutely.
Yeah.
We have a couple of Q&As in here. I want to get to those, but I have a quick follow-up question for you that was posted in the chat. So Lori, do you work with local pharmacies at all to serve your patient population?
We do, but again, with our 340B formulary, we are required to work with our contract pharmacies. And so being that there are some local kind of mom and pop type pharmacies that have worked with us on things. And so they'll do some education and outreach with us. We partner with them. They'll do screenings when we do immunization. So they do work with us on things. There's also some local ones that just out of the goodness of their heart, sometimes when we've had, for example, certain medications fall off the 340B formulary when they've become generic or they're going through licensing, that sort of thing. I have a local one in a county here that literally created their own $5 drug list just for our patients because they knew what we needed. And anytime I need a specialized kind of just, we get those rare cases. They're the first that I call. I call the pharmacist, that's in the pharmacy across the parking lot. And I'm like, hey, any idea who the drug rep for this drug is
Right.
around here? I need to find if there's a program that I can
Great.
get my patient in. So yeah, they really do support.
That's fantastic. I want to come back, Ehab, to you quickly to answer a question that was been brewing in my mind when you gave your introduction. So you mentioned about how difficult it was to kind of standardize anything. Everybody kind of does everything a little bit differently in primary care. So since you guys haven't had as much experience with that early detection or the attempt to standardize it anyway, what is sort of your vision at UTSW and Parkland, sort of in the near term and then in the future for early detection through this program?
Yeah, thank you. All right. I think, yeah, absolutely. I think the heterogeneity across the campus has been really an eye-opener for us. I think what we have done so far is inventory, at least kind of what people are using, are comfortable with using in terms of tools. And we had a couple of, kind of top, I guess, tools people use, which is the mini cogs, which seem to be the one that a lot of our practitioners seem to be very familiar with, seem to be very comfortable using. So starting from the kind of the most prevalent tool is we're trying to kind of make that tool more readily available and maybe transform it into a digital form so that it's available and embedded into their workflows. And I think that's really has been a good selling point to a lot of providers that we've talked with, is not only having the tool readily available for them, but also kind of the action items, the workflow that they need to do after that. And we have done recently what's called an order set, I guess, in the Epic world. So providers, if they need to address or act on a positive screen, we're going to start rolling this out soon, which is, kind of these are the recommended step that needs to be made, and we're also helping with kind of next action item. So maybe that will, for as we roll that out in the future for system-wide application, having this kind of, selling point to providers across campus. Hopefully this will increase standardization. But honestly, I mean, I think just having the discussion and the conversation was by itself very helpful, because I think kind of putting cognitive health and brain health on the radar of people that we met with, and making it an initiative across, kind of having an institution-wide and a system-wide initiative has really helped a lot of just making it, kind of part of the conversation. So I think that's hopefully will lead to a standardization, but we will see, kind of in the end, how much standardized we are going to be at the institution level.
Great. Thank you so much. So we are running a little short on time here with the panel. There are several questions in the Q&A section. So what I'll do, panelists, is I'll ask you to take a look at that Q&A and kind of answer in the chat after we finish up here with our live version. But I want just sort of one more response for everybody in 15 or 20 seconds. There's a lot of people probably out there that are thinking about, these seem like great programs, something I may want to start. So if there are health system leaders on this call that are considering implementing early detection, or Greg, in your case, hiring a BHN or creating a position, what advice would you offer them in a few words? And Greg, we'll start with you.
Okay, sure. So I think the first thing I would say is plan carefully. Determine what you see as the value, and then map out a process that delivers that value, and then communicate, and embed that into the program so that you get the referrals that you need in order to drive you to financial sustainability.
Great, thank you. Elise, we'll move to you next.
I'm sorry, I think I froze
Sorry.
for just a second there. I agree. I think it's about the planning and then just the communication as well. And you don't have to be super sophisticated to start. I think that's what we're learning in this is that start where you can and make the changes that you are, and you'll be able to improve over time. And that's what's going to drive the value to your clinicians and to your members.
And Stephanie?
Yeah, I think I can't say enough about the work that DAC is doing as we've been learning from each other. It's so helpful to hear others trying to tackle the same problem. All of us are really, or the same opportunity, however you want to phrase it. All of us are really trying to do better for patients and to get them access to care. Probably the best advice I have, aside from learning from the path that others have already started on, is also to really understand and define both who you're trying to serve and who you can serve. We had to really, in the cognitive neurology side, understand with so few cognitive neurologists in the country, who can we be and who can we not be, and then who can meet the needs if we can't meet them all. And so understanding that, and also understanding the value of partnership and education with the people that are closest to those patients that we want to reach. And so I think primary care partnership and education from day one has been invaluable in us trying to reach more patients.
Fantastic. Lori, a quick word about what advice you would have.
Yeah, I just echo Stephanie there. The partnership and learning from others has been just beyond anything we could ever place value on. The only thing I would say is in our setting was just be prepared for bumps in the road. You know, we sometimes, and scalability, sometimes we have very high aspirations because we want to do everything we can for our most vulnerable. And I would just say, be aware of practicality and scalability of your reach of your program.
Thank you. And Ihab, we'll give you the last word before we turn it over.
The last
to our
word.
next speaker.
I would say baby steps is a good kind of way to approach this. I think we all want kind of a big program to focus on brain health, but unfortunately the reality is you can probably insert brain health into the health system in a small corner. So that I think that's important to put expectation that if we are able to screen few more people and get access to few more people, that's an accomplishment, because I think we all have a tendency to want to achieve a lot, but sometimes reality hits us hard. So I think it's baby steps is really what I have been trying to kind of recalibrate myself.
Well, thank you. And I want to thank each of you for taking the time out this morning to be part of this panel. I think we presented a lot of great information, and do take a look at the Q&A and try to answer those questions for our audience members. So with that, I would like to welcome DAC Chairman and Founder, George Vredenberg, who will lead us in our final discussion for today's meeting.
Thank you, Michael, and thank you, panelists. Thank you for everyone who has participated in this meeting so far. I find it fascinating. It's the nuts and bolts of trying to move a health system that's not used to dealing with brain disorders and beginning to get brain health built into these systems is non-trivial, shall we say. And it's hard work and innovative work, and everyone who's participated to this session today is deeply involved in that, and I'm eternally grateful. I've lost 3 generations of my family to this damn disease, and I am hopeful that it does not extend to my kids and grandkids. So I want to welcome you all to this last panel of the day, and this will take us to a different setting. We're going to be focusing on the Global South and specifically Africa, and in doing so, obviously, we're moving to a different setting. A non-neurologist focused healthcare systems, a non-high equipment scanning environment, and also an environment with different demographics. So I am pleased to have an extraordinary panel here from who is doing a great deal of work in Africa, both as part of DAC and as independent of DAC. And I would like to have each of them introduce themselves. May Rizik is the first one up. May, could you introduce yourself, please?
Yeah, hi George and hi everyone. So my name is May Rizig. I'm a neurologist and a molecular geneticist. I'm a senior clinical research fellow currently working at UCL Queen Square Institute of Neurology. My research interest is understanding the diversity in neurodegeneration from ancestral point of view. I focus my research in African and African admixed populations, and I've been lucky to work with several collaborators on these subjects in Africa and outside Africa within the last few years, and I'm glad to be with you here today.
Zul Morali.
Thank you. Thank you, George. Zul Morali, I'm the founding director of the Brain and Mind Institute that has a hub in Kenya, Nairobi, Kenya, and in Karachi, Pakistan. So we're serving East Africa on the one hand and South and Central Asia on the other. Happy to be here. Our focus primarily at the Institute is brain health and mental health, and we're working very closely with DAC to actually change how we provide care in those countries where of high need.
Thank you. Thank you for joining us, Zul. Thank you for your partnership. Vaibhav Narayan.
Thank you, George. Hello, everybody. My name is Vaibhav. I am currently heading the Global Cohorts Program at the Davos Alzheimer's Collaborative. My big background is mainly in data sciences, digital health, and neuroscience, biomarker, and drug discovery and development. I came to DAC after many years at Johnson & Johnson and Eli Lilly before that. And prior to that, I was 5 years working on the human genome sequencing project.
We have a further panelist, Mathoni Gichu from Kenya, who I don't see on video, but we know she's online. So when she joins us, I'm going to ask her to introduce herself. Zul, I'm going to start with you. Oh, there she is, Mathoni. Thank you for joining us. If you could just introduce yourself, I would very much appreciate it. Mathoni, could you introduce yourself?
Oh, yes. Sorry for that. My name is Mathoni. I work with the Ministry of Health, and I work in the division of geriatric medicine, and I am a healthy aging champion.
Great. Thank you for being with us. Thank you all for being with us in your various parts of the world today. Zul, I want to start with you, if I could, and just give us a little a taste of the different context we find ourselves when we talk about Africa, both in terms of the lack of the shortage of specialists, shortage of high-end equipment for imaging the brain, the demographic change and differences that exist there. One of the main core elements of why DAC was founded was to link global developments in the South and the North. And so we should understand our respective contexts, so to speak. So Zul, if you'll start.
Yeah, thank you, George. Yeah, so I think that you described it correctly. I think in the low resource settings like we find ourselves in Kenya, there are a couple of issues that are really glaring us in the face. And one is I'll start with the demographics. In the sense of the demographics, we all know Africa is a young continent. So in Kenya, it's true that the median age is 2021. That means half the population is under that age. But what's very interesting as well is that as the communicable diseases have come under control, people are starting to age more normally now. And as a consequence, there is an expected 300% rise in the elderly population in Kenya by 2050. So it's a huge onslaught. And with that aging population, of course, conditions like dementia are extremely important and coming fast and furious at us. And what that's also telling you is that here's an opportunity where we need to kind of focus across the lifespan rather than waiting for the late stage. And here's a situation where you can learn a lot more about what are some of the modifiable risk factors and what are some of the conditions that are making people predisposed to dementia, and kind of apply it earlier in the population so that you can mitigate that trajectory quite effectively. The other thing that George mentioned that's important is that in these settings, particularly in the rural areas, access to care is very difficult, and you don't have the traditional tertiary specialty hospitals, even when you're struggling with primary care access. And so how do you actually bring help to those that are most in need, and find ways of actually doing the detection, early intervention, and then referring them up to higher levels of care as is needed, triaged that way. And so we're working very hard to actually be closer to the communities, closer to their doorsteps. So how do you begin to identify people who are at risk? Some of the tools that exist currently that we have inherited from the global north are not always appropriate for our populations. For example, one of the tests will require people to draw a clock face and show the time, like an analog clock face. Well, when you go to the rural areas, these people have not seen an analog clock face. If they've seen anything, it's a digital one. And secondly, they've never used paper and pencil. And so how do you apply those tests that are supposed to be gold standard to the populations here? So we're working with DAC, and we've done an assessment in the communities about what their needs are, what's going to work, what's not going to work. Use traditional validated tools in the urban areas, create new set of tools that we can walk with them, a toolkit to the communities, being sure that they are going to be the right ones to detect them, and then take the next step on. So those are some of the contextual settings where I think it's important. And the last thing that I'll mention is that it's very important to understand those communities thoroughly. And we have, again, with the assistance from DAC, we've been able to actually do ethnographic surveys in those communities to understand our populations, because there's a lot of misconception. Very often people think it's part of normal aging. They don't know what's coming at them when dementia begins or Alzheimer's begins, and it hits them very hard because the caregiving is done essentially by the family members. So at that, I'll stop at that, George.
Thank you, Zul. Zul, you focus on going back through the life course in order to identify the risk factors for the disease and potentially shape interventions appropriate at different stages of life. But May, you actually have thought about how it is that we can, as we go back in the life course, begin to think about resilience factors, not just risk factors for late life disease, but the actual resilience factors. And so I know you have some analysis here on the demographics and the resilience factors, and I'd love to have you outline your thinking and your work there.
Yeah, so kind of it's a hard question, especially when you try to address neurodegeneration, which is a very complex process, and reflect on the lifespan as well. So in preparation for this talk, I prepared some slides. So if we can share them. So what I tried to demonstrate here is when we think about the concept of neurodegeneration is not a fixed process. It's kind of more of a complex, gradual process. And we heard from the panel, the previous panel, about risk factors, whether internal risk factors or external risk factors. So the internal risk factors are things which people inherit, and they are largely genetics related, and they are not modifiable. But the most important thing about them, they vary between populations. And then we need to consider this when we look at different populations, whether Europeans or Africans or other populations. And in addition to this, there are external risk factors. And these risk factors, we know about them from the environment, from the food, what we eat, but sometimes they go back to early life, which could be even prenatals and prior to birth. So if we can go to the next slide. So in this slide, I tried actually to introduce a third dimension where you do have the time course window. And why this time course window is quite important, because it's address the interplay between the internal factors, which are the genetic risk, and the external factors. And within the life of a person, you will have kind of accumulative risk, which will decide the right time of intervention. And because of the internal factors and the external factors vary between populations, this will reflect on the right time of intervention. You think about the time factors as like a sliding window. So if you want to slide it backward, if you're dealing with the younger populations, you start thinking about prevention and resilience rather than early detection and treatment. And this is really very important when we think about Africa. And I will try to explain this on the next slide when we compare the population in Africa to the population in Europe. So as Zur rightly said, Africa by far is a very young population. The population itself represents about 17% of the world population today. The majority of Africans are children and young adults below 40. If we go to the next section, so we can see that within the next 50 to 75 years, the population structure will be different. And the majority of the population will be within late adulthood and going to an elderly populations. When we compare this to Europe, so the European populations by far, they are very elderly at the moment, and they're smaller populations. And within the coming 75 years, if we go further to the next section, so population will shrink and will become older. So what is right in terms of intervention for the European populations might not be exactly right for the African populations, but at the same time, we learned from the lessons of addressing dementia and neurodegeneration in the European populations. Prevention is always better than treatment and less costly than treatment. So this will put us on a place where we think now within the African populations, there is a very opportunistic moment where we call it the go, no go moment. So if we intervene now with this younger population, we might be having a better outcome when it comes into neurodegeneration. So if we can go to the next slide. So the main question which we try to address is which strategies are most effective for addressing neurodegenerations and dementia in Africa, and at what stage of the life course should we be actually intervene to maximize the outcome. And the true answer to this is really very difficult to come up with one answer straight away. And this is basically the innovator's dilemma, which we're trying to address. But we were very, very lucky as a group to ask all these questions in a conference last year. The conference was arranged by DAC and Nature, and it's been titled The Future of Dementia in Africa, where about 200 scientists, academics, stakeholders, different people from different walks of life and expertise try to present the case of Africa and come with a plan of how we can move forward. And we're lucky enough to come with a strategic vision. We called it the 6x5 plan, and we're lucky actually to be supported by DAC to launch the DAC Africa Task Force. So this task force basically focused on 6 priority areas. We try to cover as much as possible areas where we can capture the low-hanging fruits within the continent's focusing in research, in innovation, in addressing how we can repurpose resources in a low resource settings, how we can break silos in research. But more importantly, we had kind of 5 identified pillars, which we thought this task force will be a very useful initiative in the continents, and is completely different from what has been launched before. And these basic pillars are addressing the life course perspective, looking at Africa in total, and try to engage with all countries within the continents, and be kind of having a approach with multi-sectoral collaboration and strong partnerships, and be more specific in terms of addressing the continents from a context point of view when it comes into cultures and values and different languages. So the task force itself has been launched last month. We're lucky to have around 6 groups within that task force. The first job of the task force will be to do some sort of homework and deep digging to come with a plan within the next year to answer this question about what is the best strategy to intervene in Africa, and what would be the right approach to do so. And these are just some of the organizations which contributed to this work. And hopefully we will be working as collective group with DACs and other organizations within the coming 5 years. So I hope that I will be better prepared to answer the innovation or the innovator's dilemma in a year time from now when it comes into the life course perspective in Africa.
Thank you, May, for those great slides and the great perspective that you bring from Africa. One of the aspects of the innovator's dilemma is whether the low-cost provider is perhaps the best innovator, because they, in fact, will have to adapt lower-cost methods to achieve the same results or better results, and that can teach the high-resource settings whether to adapt using the innovations from the South or not. So that is one of the dilemmas of the innovator, as how to innovate in a low resource setting. Muthoni, we need obviously to do this, not just researchers, but we need all sectors to work together. You, in a sense, here are representing governments and public policy figures. So I would love to have you talk a bit about the role of national governments and potentially Pan-African governments as a whole in trying to bring about a better result for Africa.
Yeah, thank you very much. So I would like to actually build on Zul's and May's conversations around, we understand the population structure is changing and we need to actually be ready. But looking at it from 2 perspectives. One is the aspect of having data that is available that will actually support the conversation about having interventions and what interventions, and also building conversations and awareness around resilience. Because again, sometimes we say that we have exposure to adversity, and that is possibly a possibility. And I'm saying possibly a possibility because we don't really have something that says adversity is equivalent to gives a certain outcome. We also need to look at the other side of, there could be different things that will happen differently in certain situations, and what is the role of these situations that could be packaged as adversity on one end in building resilience through the life course. And so what does this mean? This means that as national governments, we need to create awareness or see how to build awareness on building up a conversation around resilience and brain health and the importance of that. And also, as we build this awareness, we have various approaches that are likely to work for us. And some of those would be like investing and having conversations around strengthening the community support, which again goes to building onto the resilience, and building data that will actually inform decisions and actions we are going forward. And this means that we are able to talk about prevention and implement initiatives and measures as well as programs that are not only cost effective, but are also accessible to a majority of the population. And one very encouraging experience is that for example, if I give an example of Kenya, we have mobile phone which has an accessibility or a reach of about 80%. So this is a resource that we can use, that we need to use both to create awareness as well as to get to understand where our risk factors are and what risk factors are we talking about. So we have we have a duty to raise awareness as well as generate data that supports our decisions and actions and programming. Over to you, George.
Yeah, no, thank you very much. You're absolutely right. We can sort of leapfrog the north by using new tools that are much more accessible, low cost. And so I'm going to turn to Vaibhav, who is doing just that in our work in Africa. So Vaibhav, could you explain how it is that we're looking at new tools and new processes that more attuned to the African context?
Thank you, George, and thanks, May, Zul, and Mithoni. I think your remarks are spot on and set up nicely. I think this topic of tools and data. I mean, one of the big challenges in brain health and neuroscience is that the assessments that we use, whether it's for clinical diagnosis or monitoring the condition, are inherently often subjective, and therefore they tend to vary in performance a lot based on variations in culture, language, socioeconomic status, education status, etc. And the challenge has been that most of these tools have been developed so far in very narrow populations in the West, and applying them without customizing and adapting them to local populations results in overdiagnosis or underdiagnosis and just cannot inform good policy or good clinical practice. So there is a huge data gap that we need to fill. And this is exactly what we are trying to do through DAC's Global Cohorts program, where we are going to under-resourced and underrepresented regions around the world and collecting data and with the goal of locally adapting and validating tools for good diagnosis. And I'll come to the risk and resilience later, but even for, say, assessment, we are doing things like, as Zul mentioned, really understanding, do these tools apply locally? Do the communities accept them? Through ethnographic studies and through focus group work, we are developing local normative data so that we have good cutoffs available in the local regions per se. But beyond just taking existing sort of tools and localizing them and translating them and developing local norms, I think the other big promise we see is that there are new technologies emerging. For example, voice-based biomarkers, ocular eye-based biomarkers, olfactory test-based detection systems that may inherently, biologically, be more robust across variations in language, cultures, and education. And so we are collecting tremendous data from multiple regions, including in Africa, in these digital biomarkers arena to really with the goal of coming up with more language and culture fair, more objective assessments of brain health, which would be necessary to really target the right interventions. And I would also say also takes away from some stigma associated with diseases when you can really objectify these conditions in a more reliable way. And we think that this does not have to be a lofty goal. of course, having an acoustic biomarker or a speech-based biomarker that works across all cultures and languages is fantastic. But we are already seeing signals that even taking existing tests, speech-based tests, and doing simple innovations like allowing language switching, which is so common in Africa where people speak multiple languages, can greatly enhance the robustness and sensitivity of these tests. So a lot of innovation to come in that space. And the next thing I want to say, in addition to this diagnostic and assessment tools, is really, I think, the point that Mithoni, you also brought up, and May and Zul also brought up, is that the other data gap that we really need to fill is about what risk factors are and resilience factors are really operating in these populations. And the fact is that unless we can stratify populations by risk and resilience, you really cannot target interventions well. At a population level, you cannot identify the right subpopulations that are at higher risk that you can sort of intervene in. At an individual level, you can not identify the right timing of when to intervene in somebody for appropriate intervention. And so the other data gap that we are looking to fill is to really understand both the prevalence and relevance of different risk factors and resilient factors across different geographies around the world. So for example, in Kenya, risk related to high levels of heat, high levels of crop failure-induced anxiety, high levels of migratory stress might be quite relevant to brain health. In Egypt, we are collecting data related to air pollution and the impact that has on brain health. In Chile, for example, we are collecting data related to toxins from pesticides, but we are trying to standardize as much as possible. And I think that I just want to highlight, I mean, we're not going to solve DAC alone, this problem, but I want to highlight the importance of really collecting data related to risk and resilient factors as they vary across different regions, including, and then as May said, also understand the impact these risk and resilience factors have on the biology and the biological sort of epigenetic and exposomal changes. And I think that's the data gap and the insight gap that we really need to fill if we have to really achieve this life course approach of early detection, prevention, and better care.
That was terrific, Vaibhav, and to all of you, I have really brought out the distinct challenges in Africa and the distinct opportunities in Africa to really innovate on risk and resilience, which is not a major part of the conversation in the high resource countries, which is basically how do we get rid or diminish the use of PET scans. This is not an issue in Africa. There is no PET scans. How do we actually enhance the capacity of neurologists to make diagnosis? Very few neurologists in Africa. So Africa is, in a sense, understands the problems and the opportunities, and also takes those unique opportunities and challenges and innovates in ways that is, in fact, probably going to be teaching the global north much more scalable and accessible solutions in the global north. We heard from the earlier panel about fairly qualified health centers in the United States, which serve low resource settings in the United States. It's a natural conversation to say what in the heck we can learn from each other with respect to low resource settings, even in high resource countries, because there's a lot of low resource populations in the United States, Europe, Japan, and China. Thank you all very much for your comments and really brought out the distinct characteristics of Africa. Just in closing, we only have a couple minutes left, indeed 1 minute left. Let me just thank all of you and all of the participants in today's panels and speakers. And there is some almost unique value associated with these learning labs where we are hearing each other in different contexts and learning from each other and learning where the opportunities may lie for increasing collaboration. No one individual, no one company, no one researcher is going to solve this problem alone. We're going to need the governments and policy incentives. We're going to need researchers to get the right data to give us advice on how we best ought to intervene. We need people who are designing those interventions at a population level at scale, because most of the dementia of the world is going to be in the global south, and we can learn a great deal from the north, and we can teach the global north a lot about how to detect and diagnose and reduce the risk and increase the resilience of populations across the life course. DAC's mission is basically to link the global north and the global south so that they can learn from each other and innovate in their different ways and bring those innovations at scale to all of those who are at risk of or have dementia. So I want to thank particularly Tim McLeod for his leadership on this Davos Alzheimer's Collaborative Health System Preparedness Working Group and in organizing this DAC Learning Lab, and to Phyllis Farrell, who is sort of the originator of this and has now still a participant, still our partner, and who has provided the energy and imagination that we've needed in order to drive us from working with 9 health systems to now 70. So thank you all for participating today. Thank you all for your involvement every day in what you do. And I wish you all a happy day, and happy evening, or a happy morning. Take care.